Nico, can you hear us?
Yes, I can hear you, and I can.
Okay, so we can get started here. Good morning, everybody, and good afternoon. Professor Marx, welcome to Grand Rounds, an event that is a partnership between the Medical and Teaching Board of Directors of Hospital de Clínicas de Porto Alegre and the School of Medicine of our university. My name is Luis Eduardo Rode. I'm the hospital director and professor of the cardiovascular division. Today we are honored to have the virtual participation of Professor Nicholas Marx, Professor of Medicine, Head of the Department of Internal Medicine 1 at the University Hospital of Aachen in Germany, who will talk to us about cardiometabolic risk and comorbidities, practical guidelines for physicians. Professor Marx is a leading global investigator in cardio-renal and metabolic interactions and was the leading author of the recent clinical guidelines on diabetes and cardiovascular disease from the European Society of Cardiology. Just to give you an example of his importance in the field, Professor Marx published 3 days ago at the New England Journal of Medicine the final results of the SOUL trial addressing the role of oral semaglutide in patients with diabetes, CKD, and atherosclerotic cardiovascular disease. We deeply appreciated the chance of having you with us today, Professor Marx, and we also be joined by Professor Fernando Gershman, Professor of the Endocrinology and Metabolism Division, and Professor Roberto Manfro, Head of the Solid Organ Transplant Division and Professor of Nephrology Division at our institutions to discuss the topic after the lecture. I wish we have a great session, Nico, with you now.
Yeah, thank you very much, Louis. It's a great honor to be with you. And let me share my screen. I can hear an echo. Can you maybe turn off the microphone from your side? Okay, it's better now. I hope you can see my presentation in full screen. Could you let me know whether you can see it in presentation mode?
It's not presentation mode. We can
It's
see
not?
the slides. Yeah,
This is presentation mode?
No, not really.
Okay. Like this?
Not yet.
Well, I think I will still. Is that okay? Because I don't know what to do now.
So let me check here. Just give us a few moments. You have to stop sharing with us and try to share the whole screen.
Okay, let me do that. Sorry about that. I'm not familiar with the Google.
It has happened a lot lately. I don't know. Maybe Google Meet has changed some of the.
To be honest,
settings.
I think it's me, but oh, here we go. Is it working?
Yes, perfect.
Very good. Okay, great. I'm glad we sorted that out. Louis, it's a great honor to be with you and to share with you practical guidelines for physicians on cardiometabolic risk and comorbidity. And this is my conflict of interest slide. I do have interaction with various companies in the field, but do not take any personal honoraria. What I'm going to do over the next 30 minutes or so is to first allude on cardiovascular risk in the cardio-kidney metabolic syndrome, and then look at various aspects of cardiovascular risk reduction in these comorbidities, with a special focus on how to implement this in clinical practice. You might have seen that 1.5 years ago, the American Heart Association published this overview article or this consensus paper on cardiorenal metabolic syndrome with the different stages, starting stage 1 with adipose tissue, additional metabolic risk factors, subclinical cardiovascular disease, and then the full picture here. And in our patients that we see in the cardiology department, I'm sure the same holds true with you. Many of our patients have, in addition to coronary heart disease, for example, they have diabetes, they have obesity, and there's a complex interaction. So let's start by looking at the cardiovascular risk in people with obesity. And this is a very large study here, 190,000 individuals, middle-aged men and women. And you can see, let's look at obesity here, BMI between 30 and 39. These individuals exhibit an increased risk for cardiovascular morbidity and mortality, and this is true for men and for women. Well, obesity has very long been considered as a cluster of risk factors, and the question came up whether there's an independent risk of overweight and obesity if diabetes, dyslipidemia, and hypertension is not present. And this has been nicely analyzed in this paper here, looking at individuals with normal weight, overweight, or obesity, and then metabolic abnormalities, none up to 3, among them diabetes, hypertension, dyslipidemia. And to make a long story short, you can see even in the absence of metabolic abnormalities, individuals, people with obesity, exhibit an increased risk to develop coronary artery disease, cerebrovascular disease, and which I think is for a long time been neglected, heart failure. So obesity itself contributes to the development of cardiovascular disease. Let's look at cardiovascular risk in diabetes, and this is data from the Swedish National Registry looking 20 years back on the incidence of myocardial infarction and heart failure in individuals with and without diabetes. And you can see over the last 20 years, I think we did a pretty good job in reducing the standardized incidence rates by implementing prevention strategies such as statin, ACE inhibitors, blood pressure control. So it dropped for myocardial infarction, but even today, the risk of individuals with diabetes is tremendously increased. The same holds true, the decrease here in individuals without diabetes, but individuals with diabetes have an increased risk to develop heart failure. And this is kind of alarming to me. It seems that over the last decade, the decreasing incidence initially has leveled out. And this is, to me, a call for action. And we will talk about strategies during the talk. Let's look at CKD, chronic kidney disease. And we've known for years that there's a very complex interaction between chronic kidney disease and its pathophysiological characteristics. They contribute to heart disease, for example, by leading to hypertrophy and fibrosis of the ventricular, while vice versa, cardiovascular disease has an effect on chronic kidney disease. And if we look at the risk of heart failure hospitalization or cardiovascular death in CKD, it is important to recognize that once the eGFR drops below 75, there's an increased risk for both cardiovascular mortality and heart failure. And in addition, eGFR only tells us something about function, but damage is assessed by albuminuria, urine albumin creatinine ratio in the spot urine. And as you can see, once UACR increases above 5, there's a tremendous increase for CV death and heart failure over time. And this is due to a very, I hear an echo again, sorry. This is also due to a very complex interaction with many factors that are not yet understood. And here in the department, we have a strong research focus on this and are trying to sort out some of the mechanisms that are shown here. let's look at CV risk in CKD and diabetes if both come together. And you've seen this slide again here, the decrease in EGFR and cardiovascular death in individuals in blue here without diabetes. But if diabetes is present, there's a tremendously additional increase in risk. And this holds true for the decrease in EGFR, but also for the increase in UACR. And this is due to the fact that there's an even more complex interaction between diabetes, CKD, and heart failure, where various factors influence each other, and underscoring the need for therapeutic strategies to interfere with this organ crosstalk. So let's look from a clinical perspective. What can we do to reduce cardiovascular risk? And let's start with diabetes. And Louis, Professor Rode mentioned already that we've been involved in the 2023 ESC guidelines for the management of cardiovascular disease and diabetes. And this is the central figure of our guidelines. And we put a strong emphasis on the evaluation and identification of individuals with these comorbidities, both comorbidities, cardiovascular disease and diabetes, or diabetes and cardiovascular disease, also kidney disease. We'll come to that in a minute. And then in the second part, we give clear evidence-based, patient-centered recommendations for those individuals that have, for example, diabetes and atherosclerotic cardiovascular disease, meaning coronary artery disease, peripheral artery disease, or cerebral vascular disease. So most important, and here it comes to the practical recommendations, we need to identify patients with diabetes among those that we are seeing in cardiology. And there's a high rate of undetected diabetes in our patients, between 10 and 20%. And so we give a very strong class 1A recommendation for screening for diabetes in all individuals with cardiovascular disease. And we also mention how to do that by measuring fasting glucose and HbA1c. And diabetes is diagnosed, and this is based on the WHO definition, when fasting glucose is 126 or above, and HbA1c about 6.5 or above, and then we can make the diagnosis of diabetes. So we do this in our department in every patient, and the guidelines give clear recommendations what to do. If you're having a patient with type 2 diabetes, he had a myocardial infarction, you identify diabetes, and this is the recommendation we are giving here. And in the upper part is the recommendation for the reduction of cardiovascular risk independent of glucose control. So we are not talking about HbA1c or glucose, just CV risk. And in the lower part, recommendations if additional glucose control is needed. So for an individual with type 2 diabetes and atherosclerotic cardiovascular disease, for example, someone with coronary artery disease, we give a class 1A recommendation for the treatment with a GLP-1 receptor agonist, and we give a class 1A recommendation for treatment with an SGLT2 inhibitor to reduce cardiovascular risk independent of glucose control. And that means independent of HbA1c and independent of concomitant glucose-lowering medication. You see the little note here. The note means that we give this recommendation for agents with proven cardiovascular benefit. And at the time when the guidelines were published, these were liraglutide, subcutaneous application, semaglutide, dulaglutide, or epaglenitide. And I'm not sure which of these agents is approved in your country, but that was at that time. And Louis mentioned already that 4 days ago at the ACC, we presented data for oral semaglutide. There's an oral formulation that can be taken on a daily basis as a tablet. And in the SOUL trial, we assessed cardiovascular outcomes in a high-risk population. And this is the main outcome here. We've been able to show over a mean follow-up of almost 5 years that oral semaglutide compared to placebo led to a highly significant reduction of the 3-point MACE endpoints, CV death, non-fatal MI, and non-fatal stroke. So in the guidelines, we gave a class 1A recommendation for GLP-1 receptor agonists and SGLT2 inhibitors based on the wealth of data of clinical trials that have been conducted for both agents. But the trials were conducted in parallel and presented. The first one was EMPEREG outcome in 2015 with empagliflozin, and LEADER with liraglutide also in 2015. But it was unclear to what extent we recommend the guidelines that both should be given, but we had little data whether they're dependent or independent effects here for this recommendation. And so we published from the SOUL trial that we presented 3 days ago in parallel a paper in Circulation looking whether semaglutide has a beneficial effect according to SGLT2 inhibitor use. That was pre-specified. And to make a long story short, we looked at individuals on oral semaglutide who had SGLT2 inhibitors at baseline. At baseline, we had 27% of the patients, so a large group of patients on an SGLT2 inhibitor. And you can see here, compared to placebo, there was a reduction in 3-point MACE, and there was independent whether the patient were on an SGLT2 inhibitor or not. The p-value for interaction was not significant. And so our recommendation indeed that both agents should be given is nicely confirmed here. And so when you're seeing this afternoon a patient with type 2 diabetes and coronary artery disease, I think there's no doubt that you give him aspirin, you give him you make sure that his blood pressure is less than 129, his LDL is less than 55, but on with the same level of evidence, this particular patient needs both a GLP-1 receptor agonist and an SGLT2 inhibitor, because the cardiovascular risk reduction seen here is in the same range to what we see here. For example, in SOUL, the number needed to treat over 3 years was 50. And that's exactly in the same range of what we have seen in the statin trials. So that's why I put this here. All of these are a must. The question how to implement that from a practical perspective, well, in our department, we are screening every patient for the presence of diabetes. So we do the measurement, and if the diagnosis of diabetes is made, we immediately start therapy with both an SGLT2 inhibitor and a GLP-1 receptor agonist. In my country, these agents are only approved in combination with metformin. So we add a small dose, 500 milligram of metformin, but very important, this is not for risk reduction. Patients need these agents. And if you saw the Kaplan-Meier curves I showed you, it's an early separation of the curve. So you don't want to miss the boat and want to make sure that therapy is implemented. Of course, we refer these patients when we do the diagnosis then to a diabetologist or endocrinologist, because the patients need additional assessment of microvascular complications, for example. With SGLT2 inhibitors, we are pretty familiar due to the heart failure data, less so with GLP-1 receptor agonists. And with a couple of colleagues, we published a paper in Circulation, in particular for cardiologists, summarizing side effects, the patient profile, the effects on risk factors, but also practical recommendations how to start therapy with a low dose and slow increase and adjustment of other glucose-lowering medications. And in our department, to make sure that everybody from the youngest resident to the senior consultant knows what to do, we have what we call the white coat card here. It has all the relevant information, and this is in English now, so we have an English version too. And that helped us to really make sure that on a daily practice, on a daily basis, the guideline recommendations are implemented, because all the information is given here. I'm happy to share these with you. Just send me an email. And we, in particular, created this English version because we got a lot of requests from non-German speaking countries. So let's look at severe risk reduction in chronic kidney disease. And as said before, you're familiar with the Candida heat map, I'm sure. As cardiologists, I think we have to be honest that we never cared much about the kidney, only when we sent patients to the cath lab. And none of us would have been concerned, for example, if a patient has an eGFR of 50 here with respect to his risk, but eGFR only tells you about function and albuminuria about damage. But if this patient has a large albuminuria here, A3, it means the patient has a very high risk to develop end-stage kidney disease. Well, we might argue that as cardiologists, we don't care too much about dialysis, but if you take the same pattern from the KDIGO heat map looking at kidney failure and look at cardiovascular or all-cause mortality, you can see the patient I was talking about with an eGFR of 50 A3, he has a tremendously increased risk to die from cardiovascular death. And this is something that I think we underestimated so far. And so in our department, the approach is we measure UACR in all patients in the spot urine. And I can tell you, I'm heading a large university cardiology department. This is painful if you want to implement that, because all of a sudden physicians and nurses need to deal with urine. And we had major trouble to implement that. And everybody told me when I was asking that liters of urine got lost in the department. This is certainly not the case, but it needs to be implemented. And I think this is something, a practical approach that really helps to categorize risk and also lead to strategies, because we have now agents to tackle that. What do the guidelines say if there's a patient with type 2 diabetes and chronic kidney disease? Again, the same picture here in the upper part, reduction of cardiovascular risk, but also at this case for kidney failure risk. And so based on the evidence we are having, we gave 5 class 1 recommendations. To reduce cardiovascular risk, these patients need statins. To reduce kidney failure risk, that's what we learned from the nephrologist, they need RAS inhibition. But then to reduce both cardiovascular and kidney failure risk, these patients need to be treated with an SGLT2 inhibitor as well as the non-steroidal MRF finerenone, in addition to very stringent blood pressure control, meaning in most cases systolic blood pressure less than 130 millimeters of mercury. This is an article that will come out in the European Heart Journal next week or the week after, where we summarized current evidence and also very practical recommendations how to treat patients with cardiovascular disease and chronic kidney disease. No matter what the comorbidity is, the cardiovascular morbidity is coronary artery disease, HFrEF, HFmrEF, HFpEF, or AFib. If someone has CKD, the patient needs a statin, RAS inhibition, and SGLT2 inhibitor. And if the patient has type 2 diabetes, also semaglutide, which is not in the guidelines because that was a result of the FLOW trial published last year. But then if the patient, for example, has HFrEF or HFmrEF, there's data for finerenone. We do heart failure treatment. And if the patient has diabetes, there's also the need in diabetes and CKD to give them finerenone if they have, for example, coronary artery disease or atrial fibrillation. So let's look at some more recent data on overweight and obesity and atherosclerotic cardiovascular disease. And 1.5 years ago at the AHA, Mike Linkoff presented these data at the SELECT trial, randomization of semaglutide 2.4 milligram once weekly versus placebo. Please note the dose in diabetes is 1.0. The dose for weight loss is 2.4. Patients were randomized if they had a BMI of 27 or above and established cardiovascular disease. And most important, patients with diabetes were excluded. The primary endpoint, a classical 3-point MACE. And if you look at the population, this is a pretty sick population. 2/3 had a myocardial infarction, 18% stroke, and 8% had 2 or more of these inclusion criteria. And that's the primary outcome, a highly significant reduction of the combined endpoint of CV death, non-fatal MI, or non-fatal stroke in this population by semaglutide. Very strong weight loss here, very robust data, almost 10%, and also reduction in waist circumference. Waist circumference is a surrogate for insulin resistance, so there seems to be an improvement. Many of these patients had pre-diabetes, but as noted before, diabetes was excluded. And if you look at the various components of the primary endpoint, you can see the hazard ratio is always below 1. So these all single endpoints contributed here. And I just want to draw your attention on some of the other changes here. There was a decrease in blood pressure and also a 40% or 38% reduction in high sensitive C-reactive protein, suggesting that these agents exhibit anti-inflammatory properties, and we're currently in various studies examining whether these effects might contribute to the reduction in cardiovascular risk. So to summarize, among patients with pre-existing cardiovascular disease and overweight or obesity who do not have diabetes, once weekly subcutaneous semaglutide reduced the risk of CV death, MI, or stroke by 20%. And for the sake of time, I skipped the data, but the benefit occurred independent of various subgroups. So let's finally look at some other data in patients with HFpEF. Patients with or individuals with diabetes, CKD, and overweight obesity have a high risk to develop HFpEF. And one trial, the STEP-HFpEF trial, assessed the effect of semaglutide, again at the higher dose versus placebo, in individuals with HFpEF here. And the primary endpoint was not hard outcomes, but change in KCCQ, so quality of life, physical activity, and also change in body weight. They also included 6-minute walk test and some other parameters. And again, this is the primary endpoint, the primary outcome here. Semaglutide compared to placebo led to a highly significant and very robust reduction in this KCCQ quality of life score. And the effect seen here is the largest effect ever seen in a heart failure trial. What about side effects? Well, semaglutide in red and placebo in gray, less overall side effects, but adverse events leading to discontinuation was higher in semaglutide. Most of them were due to gastrointestinal side effects that are known. Patients often do not tolerate higher doses. Here it is very important for the daily practice to start at a low dose and then slowly increase the dose here, but about 8% of the patients can't tolerate these drugs. So in summary, in patients with HFpEF and obesity, treatment with semaglutide led to a larger reduction in symptoms and physical limitation, greater improvements in exercise function. For the sake of time, I didn't show the data, and a greater weight loss than placebo. So to summarize, practical guidelines for physician, and that's for the daily practice. Screening for for diabetes in all patients with cardiovascular disease is recommended. Screen all patients with cardiovascular disease for CKD, not only measuring eGFR, but also measuring UACR. As said, it's painful initially in the cardiology department, but it can be done. And then strategies to mitigate cardiovascular risk, very important. Patients with type 2 diabetes and ASCVD. The patient that got a stent yesterday or today in your department has type 2 diabetes. He needs all these therapies here to reduce his risk. And then we have an even more complex pattern in patients with cardiovascular disease and chronic kidney disease. And with that, I'd like to thank you for your attention, and I'm looking forward to the discussion. Thank you very much.
Thank you. Nico, can you hear us?
Yes, I can hear you very well.
Sorry for the echo. Now we're joined by Professor Manfro and Professor Gershman. Thank you for this very, very nice overview and updated lecture on these interactions of metabolic, renal, and cardiology. I think this is a new era that we're facing now with drugs that can really address cardiovascular reduction in these scenarios. So I'm going to ask our discussions to begin some questions for Professor Marks, and then we can have from the audience to anybody that wants to have a question. Professor Gershman?
I don't know where I have to
There.
sit there.
I can see you.
Okay. Thank you for your talk. It's very interesting that we are aligning the kind of recommendations in cardiology, nephrology, and endocrinology in the same way. But I think that there are some areas that we need to clarify in the future. And one of the areas that I think it's not very clear the benefit of GLP analogs it's in those that have heart failure if not preserved ejection fraction. So in this kind of patients, although we had a sub-analysis of the SELECT trial that had something like 4,000 people with heart failure, and most of them did not have heart failure with preserved ejection fraction. I don't think that these patients had a heart failure that happened in heart failure clinical trials. They are much more it was a much more mild heart failure. So the question is, we are going to have a clinical trial with semaglutide in a typical case of heart failure in the future?
Well, thank you very much for that question. You made a very, very important point. I'm not sure we are having this. We will have this trial, and I think the benefit of a GLP-1 receptor agonist in those with heart failure and reduced ejection fraction is probably less robust, the data, compared to HFpEF. But one point is important, I think. There were some very small trials with GLP-1 receptor agonists with liraglutide, for example, suggesting that there might be a negative effect on cardiac function. In none of the trials seen so far, be it those with diabetes, be it those with CKD or obesity, there was a negative effect. So it's safe, and this is an important issue. To what extent we get an incremental benefit in addition to the fantastic four MRAs, beta blockers, SGLT2 inhibitors, and ARNIs, I think is not clear, but the SELECT data indeed suggests some benefit, but not too much. But I'm not sure whether we are seeing a trial on that. But from a practical perspective, we give it to our patients with HFrEF. Yeah.
Thank you, Professor Marks, for your excellent and very practical presentation. I'm a transplant nephrologist, and of course, I work with nephrology patients across the board. From the time that they are diagnosed with kidney disease, whether they are diabetic or not. And until maybe 10 years ago, the only things that we could do for these patients were controlling the diabetes, controlling the hypertension, giving him ACE inhibitors, and that was about it. So we are sort of living a new era of a much better armamentarium for for treating patients with kidney diseases, whether they are diabetic or not. My question for you is a kind of prediction, if you can make them, if you can make it. Many of these interventions are developed initially for patients with diabetes, and they prove to be useful in reducing the decrement of the kidney function. But for some of them, we are seeing that they are also applicable later for patients with kidney disease, non-diabetic kidney disease. Can you anticipate, or in your vision, is it possible that some of them already are SGLT2 inhibitors are already used for patients without diabetes, especially for those with proteinuric kidney disease? For the other kinds of kidney disease, do you anticipate that GLP agonists or finerenone could be useful in the future? You know of any clinical trials in this direction?
Yeah, there are trials looking at this, but the data so far are not as clear for these agents in non-diabetic individuals with CKD. There's some data from the SELECT trial in the non-diabetic individuals on kidney disease, mainly slope data. And for finerenone, there is a little bit of an effect, but not that strong. But for finerenone, to the best of my knowledge, there's an ongoing trial to see whether there's a benefit.
I would like to make one more comment. When you look at the end-stage kidney disease and you go to a dialysis unit, you will see that across the board, 30 to 40% of the patients that are there doing dialysis are diabetic. and you go to the transplant waiting list, 5 to 6% of the patients are diabetics. So that tells us something. Most of the diabetics in renal replacement therapies will never make to the transplant waiting list and will never make it to kidney transplantation. That emphasizes the urgent need that we have to better prevent kidney function deterioration in people with diabetes, as well as in another disease, but diabetes is fundamental.
Yeah, I couldn't, I completely agree. This is really absolutely an important aspect. In our hospital here, I hooked up with my nephrology colleague, Jürgen Flöge, 12 years ago, and we built a cardiorenal unit. So a unit where cardiologists, nephrologists see patients together. It's also, we convinced our CEO to have a separate business unit. So, and I can tell you, I learned so much from the nephrologists, and that helped us to really understand how nephrologists treat patients, how cardiologists treat them, but for the sake of the patients. And we need to me, and that's a call for action. I think we need to leave our silos and really work together for these patients, because the main point is really to prevent end-stage kidney disease, but at the end of the day also cardiovascular disease, because many patients die before they reach end-stage kidney disease.
Nico, Carisi is here. She was very mad at me. She was wanting to talk with you before the lecture, but we're having some technical problems. She wants to ask you a question. I hope that makes it better for me.
Hi, Nico. Great
Good to see you. Good to hear you.
Yes, the same. Nico, probably I have several questions. I was just thinking, each one I will address to you, because this is a great opportunity to hear from you, someone who wrote the guidelines, the ones that we use here in Brazil, and also a major author in several of the randomized clinical trials. Two aspects. First, for us, it's really expensive, all of these new drugs. So we are talking sometimes in a public scenario and a private one, even in private. And adherence to this medication in a long term, it seems a huge problem. I don't know if you are seeing that, because sometimes people, especially with semaglutide, they lose weight, they are happy, but when this stops, they don't want to keep with the medication. I'd like to hear about that. And the other, all of the randomized trials we have is in patients with cardiovascular disease or patients already with some of the outcomes. What do you think about the future of using these drugs for primary prevention? I mean, patients with high risk of atherosclerosis or even with subclinical atherosclerosis. Are you familiar or are you aware of any randomized clinical trials in this area? And thank you.
Yeah, thanks, Carisi. Two excellent questions. I think the first, indeed, cost is an issue, but some of the agents will become off patent in certain countries next year or the year after. But beside that, I think it's important to mention that these drugs need to be taken basically forever. And if patients stop using the drug, and imagine someone in the SELECT trial who had a 10% weight loss, and he stops the drug, the weight goes up again, and he loses the effect. So this is certainly an issue. And this is an issue also with the dual agonists. For example, we have agents, GLP-1 and GIP or others. People lose 20% of their weight. But then when they stop it, they gain weight, and they really, the whole system is disturbed. So this is an issue we I think need to think about, that this is long-term treatment. And that's something we explain to the patient. But from a cardiologist's perspective and the reduction of cardiovascular risk, I think these agents have been proven to be very potent in these high-risk populations. With respect to your second question, there are, to my knowledge, no studies in primary prevention, because in the trials and also in the ones that I'm involved, we in particular pick patients at high risk to get enough events and to avoid that the trial runs forever. And many of the trials enrolled patients without diabetes, but then obesity or CKD. But to my knowledge, no data on primary prevention.
Just to remember that I think that the only trial that was designed for primary prevention was the rewind trial with dulaglutide that show reduction in cardiovascular endpoints in the population, and we are going to have in 2026, I think, or 27, the results of the trial that is comparing tirzepatide with dulaglutide, although it's not in the primary prevention scenario.
Yeah, right. That's the SERMONT trial, and they will show it. That's the trial, indeed, you mentioned. The REWIND trial was dulaglutide. There was type 2 diabetes patients, but not all of them were in primary prevention. 1/3 had cardiovascular disease, so it was a mixed population. The data, and it's also in the meta-analysis that I showed you, the data suggests that the beneficial effect in type 2 diabetes, at least in those without atherosclerotic cardiovascular disease, is less pronounced. It's still on the left line of unity, but the effect is not that strong. Thank you for raising that. It's a good point.
We have another question from Professor Luis Beck. From the
Good morning,
division.
Dr. Marks. Thank you for the nice lecture. I work personally with heart failure, and my question is regarding the dapagliflozin and empagliflozin in heart failure. We usually have some picky colleagues that want to stop dapagliflozin when the renal function goes below 20 GFR. So I would like to know your personal opinion about continuing ISGLT2 inhibitors in heart failure patients below 20 GFR.
Yeah, excellent question. So the best evidence we're having comes from EMPA-KIDNEY. EMPA-KIDNEY enrolled patient with an eGFR down to 20, and some at enrollment had less than 20, had a similar benefit. And even some of the patients went on dialysis, still having urine excretion, and it could also be given in these patients. So in our hands here, as long as the patient has urine excretion, even if he's on dialysis, we keep them on an SGLT2 inhibitor.
Thank you very much.
So a follow-up question on stopping semaglutide or SGLT2 inhibitors for elective procedures or infections or any clinical instability. What's your routine in Aachen?
Yeah, Louis, excellent question. So every patient with type 2 diabetes who gets an SGLT2 inhibitor gets what we call a sick day card, a little card like a credit card. It has all the information. Please stop it when you have a GI tract infection, if you have to go under surgery, if you're otherwise sick, because these patients are at low, but they are at risk for euglycemic ketoacidosis. In individuals without diabetes, this is not the case, so there's not the concern of that. We stop SGLT2 inhibitors 2 days before elective surgery, major surgeries in our patients. In all patients, we do that. And also if someone has sepsis, for example, or serious infections, we stop it. With respect to GLP-1 receptor agonists, there was a concern that these once weekly to apply drugs reduce GI motility, and that this could, during anesthesia, cause a problem here. There's been a very recent paper showing that this is not the case, so we stop it. We don't stop it before surgery.
Anesthesiologists ask us to stop for
3 weeks.
Three weeks, sometimes a whole month. You don't see that would be necessary. And what about oral semaglutide? How do we deal with this issue with oral semaglutide?
We have the same discussion with the anesthesiologist, and their guidelines say you need to stop it. And I sent you the most recent paper to give you the information, and you can distribute it. I sent you the paper, which nicely showed that this is not an issue. And with the oral semaglutide, this has to be given on a daily basis. It's important. The oral semaglutide needs to be taken in a fasting state with a little bit of water 30 minutes before breakfast. And we stopped that on the day of surgery.
So we have a little bit more time. We have Professor Tiziana from endocrinology. She will ask a question.
Hello, it's good night to see you. I would like to know your opinion about the use of SGLT2 in patients with diabetes and heart disease or failure heart disease and sarcopenia. What's your opinion about the use of this medication in these patients?
Yeah, it depends. So if he's end-stage heart failure, of course, in the very cachectic patients, we are coming to a more palliative state, and this is different. Otherwise, in sarcopenic patients with SGLT2 inhibitors and diabetes, we are not concerned. Only exclusion is don't give it to patients with type 1, because these patients have a high risk for euglycemic ketoacidosis. Does that answer your question?
Is there a room for one more?
Yeah, sure. We have time.
I think that my question is, I saw in your flow chart that the first step is usually to use the SGLT2 inhibitor first and finerenone last. And my question is, because we don't have, I think that real data that combine both for the treatment of the patient. So, and it looks like that the benefit is similar between them for cardiovascular endpoints. So how we can deal with the, take out the price of the products, but how can we deal with the, which one of them is more effective and in which one of in each situation?
So I think in the heart failure field, we learned we need beta blocker, MRA, SGLT2, and ARNIs. We need them all. And so far, the data that we have suggests that each of these, so RAS inhibition, SGLT2, GLP-1, and finerenone exhibit independent effects. You're right, we don't have much data. The best data we are having comes from Fidelio and Figaro, so the finerenone trials in type 2 diabetes pooled in Fidelity. Here, 8%, I think, of the patient had an SGLT2 inhibitor, and there was no sign for interaction like the ones that I showed for SOUL. So in our thinking, the therapy needs to be implemented altogether, not at the same day, but within a short time, because the separation of the curves is very early, and you want to make sure that you don't miss the boat in a certain patient by starting it only a year later.
Thank you.
Thank you. Do we have any other questions? Just a final comment, Nico, about the future in the field. What you foresee, do you have any comments on new drugs or new mechanisms of action that we're going to see in the future?
So I think 2 points. One major point is implementation. We have all this data, we have the guidelines, but if you ask among cardiologists, at least in my country, who has ever used a GLP-1 receptor agonist, it goes down to almost zero. Implementation is an issue. New drugs, I think we saw the Summit trial with tirzepatide, which is a combined GLP-1 GIP agonist. We have triple agonists now. We have additional agents, a combination of semaglutide with cangrinetide. This is an amylin analogon, which leads to weight reduction up to 20%. There's a cardiovascular outcome trial running. So I think we need to familiarize ourselves as cardiologists with these agents, because there will be a wealth of data, and they will become part of our daily practice.
just landed from the ACC meeting. We had the lecture recorded if we had any problem, but he insisted to give a live presentation. It was really, really fantastic, Nico. Thank you very much for spending some time with us virtually. The next time we're going to invite you to come personally here in Porto Alegre. We had a great session. Thank you very much again.
Thanks for inviting me. I enjoyed it very much.